Dr. Pooja Abbey is Professor of Radiology in Lady Hardinge Medical College. She has special interest in pediatric chest imaging and has many publications and book chapters in this regard. I welcome Dr. Pooja to share some interesting cases, some tips and tricks, and some learning points.
This is going to be like a case-based session. So I'll be showing a few interesting cases which we've done in the past few years at our institution, and these are all pediatric chest cases. And this is also going to be a session where I'm talking about the importance of learning from mistakes. So when I say that, that obviously does not mean that we should try to make as many mistakes as possible. But we have to realize that as clinical radiologists, when we are reporting cases and we need to give a differential diagnosis or a diagnosis, so we're not going to be correct all the time, and that's not possible. And the important thing is that when we go wrong, we should make an effort to learn from it, and that is how we'll all learn together. So just a word, when we are looking at cases and reporting our cases, it's always important to remember a few things which will help you to minimize these kind of errors or minimize the mistakes while reporting. So we keep saying this all the time, but then it's very important to remember that you should always interpret the images in the context of the clinical information. What is the age? When we are dealing with children, the age is also very important. What is the age, what is the history, and the whatever other relevant clinical history and examination. And when we're talking about chest imaging, uh, looking at previous x-rays or previous CT, previous imaging is also very, very important. Also remember that we all tend to fall into this trap of this satisfaction of search. So basically that means that we pick up one pathology or we pick up something and we're like, all right, we made the diagnosis. So it's always important to remember that there can be involvement of multiple structures. There can even be two different pathologies coexisting in a patient. So it's always important to be very systematic, and we should probably follow we should make our own approach or our own checklist. You can individualize your checklist, but always follow a systematic approach to reporting these chest cases. And also, for the sake of residents, I would like to tell you or sort of emphasize that always try to take the follow-up, because that is how you will actually learn. And we all would make mistakes and go wrong, and once you find out what the case actually turned out to be, that is when we're going to learn. And when there is any sort of discordance, always discuss with your clinical colleagues or even your pathology colleagues, because it's always a multidisciplinary team approach that works. And I'd just like to pause and acknowledge a whole lot of people. At our institution, we have a very good pediatric pulmonology setup, and we learn a lot from them. They do a lot of bronchoscopies, and they give us a lot of follow-up, and it's a mutual learning. So all kind of learning is actually, it's always a teamwork. And I'd also like to acknowledge my radiology teachers, my faculty colleagues, and my residents. And all these cases are basically, it's always a team effort. Okay, so with that, let me start with the first case. So this was a 1-year-old girl, and the history was kind of a bit vague also, but a sort of longish history of cough, respiratory distress, some fever also, and she had history of recurrent nebulization also since the age of about when she was 3 months old. And they felt on clinical examination that there was decreased air entry on the right side. And this was the chest radiograph, representative chest radiograph. So what do we see here? We can all clearly see the abnormality here, right? And this is definitely in the lung. And what is it actually? So there is a focal hyperlucency, which is seen here. And in the region of basically the right mid zone, and probably a part of upper zone, lower zone is also involved. And there is some mass effect, because there is some rotation, but still there is shift of the mediastinum, which is seen towards the contralateral side. So definitely some mass effect as well. And so in children, when we look at this kind of a pathology, a couple of things that spring to your mind, or that should spring to our mind. One is congenital lobar overinflation, because this looks like overinflation of a part of the lung. That's what happens in congenital lobar overinflation. And so that was one possibility that was thought of. And then when we are dealing with children, the other important thing to remember is foreign body. So the possibility of a foreign body aspiration. So with this kind of a differential diagnosis, the case was referred to us for a CT of the chest. So these are a few of the images. I'll show a few more images subsequently. So at the first look, what do we see? We see that on the CT, these are the lung window sections, axial, coronal, one sagittal section. So our preliminary suspicion is confirmed that yes, there is hyperinflation of a part of the right lung, right? And then we have to kind of define what is the part of, or what is the area which is involved. So on the sagittal, we can see that this seems to be the major fissure or the oblique fissure, and this is the horizontal fissure. So what does that make this to be? This looks like the right middle lobe. So there is hyperinflation of the right middle lobe, which is seen here. Let's look at a few more images now. So going above downwards. So that's the trachea here. And what is all this? These are probably areas of patchy areas of collapse, which are seen because of the mass effect. So now we see on this image, we can see the area of the hyperinflated lung, and that seems to be bound by the fissure here. And then going down, going down, going down, we see this hyperinflated part of the lung, right? And the other, these areas which are seen are probably just kind of passive atelectasis. So what else should we look for now? On the lung window, we should always look at the airway as well, especially when we are dealing with the overinflation. We had thought of possible foreign body. So we could not really figure out, or we could not see any definite foreign body here. So then thought process was, okay, maybe some kind of congenital lobar hyperinflation, because we see that quite often at our institution, because the pediatric surgeons operate on these cases. So a lot of cases come. One little thing here, if somebody has kind of picked up, is that a part of the overinflation appears to be in the lower lobe as well, because this is the middle lobe, which is on one side of the oblique fissure or the major fissure, and probably part of the lower lobe as well. One more thing that I'd like to kind of highlight here is, when we are dealing with these kind of pathologies, and we have to figure out the location where which part of the lung is involved, always remember that you should uh, the fissures are good to kind of, they are very helpful to for you to figure out and localize the pathology. Also look at the bronchial connection, look at the airway, trace the bronchi. So that helps you to figure out what is the part which is involved. So this is the trachea, then this is the level of the carina, and here there seems to be a slight extrinsic impression here, but we'll come back to that probably later. And then this is the right main bronchus, and then subsequently this is actually the right upper lobe bronchus. So part of the right upper lobe here is collapsed. Then what do we have next is the bronchus intermedius, and then this will divide into the middle lobe and lower lobe bronchi. So that also confirms that yes, this is the middle lobe bronchi here, and it is the middle lobe which is involved, right? So okay, some coronal and sagittal images like I showed before. So that is the right upper lobe. This is the fissure. This is the right lower lobe, and there is hyperinflation of the middle lobe. And probably a small area here in the lower lobe also appears slightly overinflated. Okay. So, all right. So we're thinking we couldn't see a foreign body. So probably congenital lobar hyperinflation. So just a few slides to recapitulate what we know about congenital lobar hyperinflation. Uh, it is basically progressive hyperinflation of a lobe, and it is more common in male babies. Ours was a girl, so I mean that doesn't really help us. And it can be symptomatic. It can cause a lot of mass effect. The children can have respiratory distress, and they can need emergency surgery. So it's important to diagnose this condition. Why does this hyperinflation happen? So it is thought to be because of a ball valve kind of effect, where there would be partial obstruction of the bronchus, so progressive overinflation. The cause, no cause may be found in about 50% of cases. And sometimes there can be an extrinsic compression which is picked up on CT, or an intrinsic abnormality of the cartilage of the bronchus. And CT usually is diagnostic to pick up this entity. Distribution is also important to know. So most common involvement is the left upper lobe. Usually one lobe is involved, right? More than one lobe is involved in very few cases, but left upper lobe followed by middle lobe. So that is what we had. So maybe we are dealing with that, but I haven't yet shown you the mediastinal window, right? Okay, so we'll come to that. One more thing which is important is that congenital lobar hyperinflation, most often 95% of these cases would present by 6 months of age. So this is odd because our child was already 1 year old. And so the presentation after 6 months is kind of uncommon in cases of congenital lobar hyperinflation. So then looking at the mediastinal window, what do we see here? There was definitely evidence of lymphadenopathy, right? There was right paratracheal lymphadenopathy, which we saw, and slightly heterogeneous kind of enhancement of that lymphadenopathy, and here as well. Then precarinal lymph nodes are also seen, which are enlarged and causing extrinsic impression on the carina here. So that was about what we saw. So we are still not sure what we were dealing with at this particular point. Uh, but working diagnosis was, yeah, probably some sort of congenital lobar hyperinflation, maybe some sort of superadded infection. We were not sure. So they went ahead, they did a bronchoscopy. What did the bronchoscopy show? The right upper lobe bronchus was seen to be angulated superiorly. So this is what we see here as well. That's the right upper lobe bronchus angulated superiorly. Then the right middle lobe bronchus actually showed granulation tissue almost completely blocking the lumen. So if we go back to the lung window sections, we can see actually here that these are actually the medial and the lateral segment bronchi of the middle lobe bronchus, the segmental bronchi. And in this region here, you can make out that there are these small partial filling defects which are seen within the bronchi here. So there is actually an intraluminal pathology here, which we had kind of overlooked. Okay, the right lower lobe bronchus was found to be normal and the left-sided airway was normal. So this granulation tissue that they found, they kind of sampled that, and it turned out to be tuberculosis. So we did have a clue actually. Those enlarged lymph nodes were there, but they were not like frankly necrotic. And I mean, we saw them, but we couldn't put everything together. So in small children, there is this entity called lymphobronchial tuberculosis. So basically, it is common in young children and in infants because the airway is smaller in caliber. And the airway involvement, basically what happens is that there is tuberculosis, which is involving the airway. So that is what is called lymphobronchial tuberculosis. And usually you see both things. So you see enlarged lymph nodes and you see the airway involvement, hence the name lymphobronchial. And it can cause extrinsic compression. So the airway compression can be either extraluminal because of lymph nodes, or there can be an intraluminal component. There can be inflammation of the bronchial wall, there can be caseation, and like in this case, they found intraluminal granulation tissue as well. So then that will cause these secondary effects. There can be collapse, there can be hyperinflation, there can even be distal consolidation and cavitation. So that is what this was. This was a case of lymphobronchial tuberculosis. Okay, so just a companion case. I had put this as a SCII case of the month many months back. So for those of you who haven't seen it there, I just kind of brought it back. So this was a 3-month-old male and had respiratory distress for a month. And reduced air entry was found on examination on the left side. And this is the radiograph. What we see here is there is hyperinflation, which is seen to involve the left hemithorax. And we can still see the lung marking. So this is hyperinflated, looks like hyperinflated lung. In addition, we can see this mass effect on the trachea. The trachea is seen here, and the mediastinum is also shifted. So there is mass effect. And there are some small infiltrates, something which is seen here, right? So now the age, in this particular case, the age is 3 months. So 3 months, we won't think of foreign body because foreign body is usually the age is like 8, 9 months and above to up to 3 years. Typically, when children become mobile, they start crawling, then they will pick up these foreign bodies and ingest them. So 3 months foreign body is out. We have to think of some congenital condition. That is, commonly what we would think of. So congenital lobar overinflation, that's one possibility. Otherwise, there can be extrinsic airway compression due to some sort of mediastinal pathology like a bronchogenic cyst. So we should go ahead with the CT to look at what is happening. And these are some of the CT images. So this child was intubated. So that's the endotracheal tube, that's the Ryle's tube in the esophagus. And what do we see here? This is thymus anteriorly. This is a part of the collapsed left upper lobe. Okay, so this kind of wedge-shaped opacity here with some sort of fluid bronchogram which is seen within. That's a part of the collapsed left upper lobe, and those are the great vessels. So there is some soft tissue which is seen here in the mediastinum, and this is closely related to the airway, and it's causing narrowing of the left main bronchus, which is seen here. So the lung window also showing this, confirming this airway narrowing here, which is seen here. And there is collapse of the left upper lobe, and there is hyperinflation of the left lower lobe. So though those of you who noticed, or I'll repeat it here, that congenital lobar overinflation usually will not involve the lower lobes. So involvement of lower lobes is quite uncommon. In addition, we are getting findings in the lung. So what are we seeing here? We are seeing an area, a nodular kind of opacity actually, and there is cavitation as well. So in this particular case, looking at these findings, lymph nodes, plus this kind of lung opacity with cavitation, we thought of the possibility of tuberculosis, right? And subsequently, they did a bronchoscopy. They found only extraluminal obstruction in this particular child, no intraluminal finding. They did gastric aspirate, they did a BAL, but everything came out negative for tuberculosis. They could not microbiologically prove tuberculosis, but they started ATT, and the patient actually responded to ATT. And the follow-up chest radiograph here shows very nicely that the narrowing of the left main bronchus has opened up. And this is nothing but the thymus in this child. So don't get confused with this. So this is essentially a near normal chest radiograph on follow-up. So this was also a case of tuberculosis. Okay, moving on to the next case. So this was a 2-month-old male baby, and had been unwell, had been admitted at a different hospital also, had received IV antibiotics. Basically, the complaints were fever, cough, fast breathing, and the child needed to be on ventilator support, etc., had been quite sick. This was the chest radiograph. So what do we see here? On this frontal chest radiograph, we see this very homogeneous kind of opacity, which is involving the right upper zone, mid zone, part of lower zone. It has a convex lower margin. We're not able to appreciate any air bronchogram. We're not able to appreciate any frank cavitation. And the left lung appears normal, CP angles, everything looks normal. Not too much of mass effect, which is evident here, maybe a little. But here the history was quite clear that there is some sort of infection, and it's a bad sort of infection. But what came into the mind of the clinicians was that is there some sort of underlying congenital abnormality which is getting secondarily infected, right? Because in a small baby, that is what you need to rule that out. So we did a CT for this case, and the working initial diagnosis was some sort of infected bronchogenic cyst or infected CPAP. So these are the CT images. So what do we see here? First, the location of the pathology. Definitely, this is in the right upper lobe, and this is actually the fissure, and there is bulging of the fissure here as well. So the entire right upper lobe is otherwise involved. Very hypodense looking appearance. So can this be like an infected cyst? But if we see carefully, what are these structures which are seen within this? So actually, these are areas of normal lung parenchyma and vessels. We could make out some enhancement also. So these were enhancing structures which are seen passing through the lesion. So that will not be seen in any kind of cyst or any kind of space occupying lesion. So basically, this was a case of necrotizing pneumonia. That is what we gave on the CT. So necrotizing pneumonia basically means that area of consolidation that happens in infection in pneumonia. It is no longer showing any enhancement. There is necrosis which has occurred, and the next step could be that if there is communication with the airway, this necrotic content would be expectorated out, then we can see cavitation within this. And if it becomes like a very well defined, well walled off kind of lesion, then it becomes an abscess. So necrotizing pneumonia, cavity, lung abscess. Uh, here this is what we labeled it as a necrotizing pneumonia. There was a small lymph node which was seen here, which would happen in infection. So that was kind of, apart from that, the other lung was normal. And for evaluation of the airway, here are the lung window images and the minimum intensity projection image, which is also very good always for evaluating the airway. So we can see that's the trachea, there is some mass effect, that's the esophagus, that's the level of the carina and the right main bronchus here. So there is definitely some narrowing of the airway on the right side. And lower down, there seems to be more narrowing here at the level of the upper lobe bronchus, bronchus intermedius, and then lower down we can see the middle lobe and the lower lobe bronchi here. And part of the right lower lobe is seen, which is aerated. So we kind of told them that no, it's not like it doesn't look like a underlying congenital lesion, looks like a necrotizing pneumonia. This was the appearance on ultrasound. Ultrasound is also quite helpful in evaluation of cases like this. So what do we see here? This is one small air speck which was seen within it. Otherwise, by and large, we could not see any air bronchograms within it. What we saw here, what are these? These are branching linear kind of structures which are fluid filled. So these were fluid bronchograms which we could see within. The color box is just to show that these are not vessels. So these are not enhancing, and these are fluid bronchograms. And there was an area, probably the ultrasound I think was done like a couple of days after the CT. So there was an area of necrosis, little more liquefied area which we could appreciate, not a frank abscess yet. So again, they did a bronchoscopy. So what was found here? The right main bronchus was compressed, and there was granulation tissue which was seen at the origin of the right upper lobe bronchus. And the right upper lobe bronchus was then kind of completely obliterated, or they could not see anything further. The rest of the right-sided bronchi they showed some extraneous compression, partial collapse kind of thing. But then when the granulation tissue was sampled, this turned out to be tuberculosis as well. So maybe the clue should have been that it was a longish history, though it was a small baby, just a 2-month-old baby. But baby had been unwell for a month or more, already received a lot of IV antibiotics, everything. And in our country, we know that any kind of pneumonia which is not getting corrected, we have to think of tuberculosis. But this kind of, mass-like consolidation appearance in tuberculosis, uh, not that well described, but we have seen cases, more cases subsequently. We've seen larger children as well. Though the literature says that this is more common in infants and small babies, we kind of have seen it now in older children as well. So it's important to correlate with the clinical duration and the clinical symptomatology. And subsequently, the history of TB contact was also taken. This child had a positive history of contact as well. Since this was such a small child, possibility of congenital tuberculosis was also thought of. So congenital tuberculosis, for the diagnosis of congenital tuberculosis, there are certain criteria, and which are mentioned here. So tubercular lesions in the first week of life, primary hepatic complex, or proven tubercular infection of the maternal genital tract or the placenta. And so all these findings were not there in our case. So this was not congenital tuberculosis, but acquired after birth, presenting as a mass-like consolidation. So just another sort of companion case. So the fact that I've put it as a companion case should be the clue that this is also, the appearance is different, so it has to be the etiology, which is similar. But then when we first saw this case, we had a very incomplete sort of history. And this was the history with which I saw the CT. This was a 12-year-old girl, history of fever for 1 month. And this was a very, these were the CT images, a lot of cystic areas. If we look carefully, then we see that there is definite evidence of air leak. So there is pneumomediastinum here. And what is this? We can see a vessel, we can see air or all around that vessel. So that means this is pulmonary interstitial emphysema. Though there was no frank pneumothorax that we were seeing, but there is pneumomediastinum, there is pulmonary interstitial emphysema. Apart from that, though, there are definitely some cysts which are seen here, which are within the lung parenchyma. So all of it is not cysts because of air leak. There are some cysts in the lung parenchyma. So probably these cysts would have ruptured and caused this air leak phenomenon, right? So these kind of cysts in children, normally we think of disseminated Langerhans cell histiocytosis or LCH. Though this was an older child, 12-year-old girl, this kind of disseminated LCH usually we see more often in younger children. But that is what was the first impression when we saw these images. Then, when we kind of took out the form and the entire history, diagnosis, everything was there actually. So this was a child of autoimmune hemolytic anemia, receiving steroids and developed disseminated tuberculosis and had basically a miliary kind of tuberculosis. And then she had been admitted, she had even been on ventilator support. So that can also be one predisposing cause why she developed this kind of air leak. And they actually she developed subcutaneous emphysema, so they got a CT done to rule out pneumothorax and to look at the extent of air leak. And then the other important clue was here. So looking at the, we did a contrast CT, but we couldn't see any lymph nodes in the chest. But in the upper abdomen sections, we can clearly see a lot of necrotic nodes in the peripancreatic region. So that itself is such a big clue that this was actually tuberculosis. So these were some of the radiographs of this child. This was earlier on before she developed this kind of air leak. And we can see bilateral opacities, infiltrates in bilateral lung fields. And this subsequent radiograph very clearly shows this large area of subcutaneous emphysema and pneumomediastinum and all this kind of air leak. Luckily, this child did well on tuberculosis, and after completion of therapy, her radiograph looks absolutely kind of fantastic and normal. So she did well. And this was actually the first case that at least I saw of this kind of cystic appearance of tuberculosis. And then we read up, and these kind of cysts in tuberculosis, there are a lot of pathogenesis which have been described. And it is said that majority of these kind of cystic tuberculosis occurs when it is a very disseminated sort of miliary tuberculosis, lots of lung nodules and all. So when they are, from the nodules, later on, usually these cystic areas develop. So, for those of you who have previously attended Rama Ma'am's lectures, either at the Vellore initial SciCon in 2019, Ma'am had shown this case, and then subsequently at Patna as well. So, this is a different case that we saw later. This particular case has a lot of nodules as well. So, this was also a case of tuberculosis, miliary tuberculosis, and some cystic areas also, which we can see here. And typically these cystic areas, then usually, a lot of these babies develop pneumothorax. Like here we can see this large pneumothorax on the left side. So it's important to be aware of this kind of appearance of cystic changes in tuberculosis. And usually these are associated with biliary tuberculosis. And a lot of times these children end up developing air leak and pneumothorax. So uh, that's important for us to know, because sometimes it can be a very confusing appearance if we don't know the whole history. Then we kind of label it as a different etiology for the cystic lung disease. All right. So I'll go on with the next case. This is a 14-year-old girl and had cough, coryza for 2 weeks and had some difficulty in breathing, had some bilateral chest pain. And she actually was undergoing treatment elsewhere, I think, initially. And a pleural fluid analysis was done. So she had bilateral pleural effusion, right? So that's a radiograph, and clearly we can see there is bilateral pleural effusion, some amount of loculation probably on the left side, which is seen here. And on the right side, there is an air fluid level, which is seen. So small amount of hydropneumothorax kind of appearance here. So the pleural fluid analysis had been done, and it showed a lot of cells. A lot of cells were there in the pleural fluid. So that suggested possibly some kind of infection. And she received treatment for that. She received injectable antibiotics as well. And now, if you look carefully at this chest radiograph, actually, there are some findings, other findings as well. So there are bone lesions. There is one lesion seen here. There is another lesion here. There is a rib lesion here, possibly another lesion here. So this child also had these kind of lytic lesions in the bone. Okay, so basically, because of her pulmonary, because of pleural effusion and respiratory distress issues, she came to the pediatric pulmonologists, and they called up to say that they had a case like this, and they had, bilateral effusion and some bony lesions. They were thinking in terms of some kind of malignancy. That was their working diagnosis. So they said that should we go ahead with a CT chest abdomen? And that is what was done. The working diagnosis was a exudative bilateral massive effusion and either LCH lymphoma hematological malignancy. So this is the CT. So the CT, contrast enhanced CT, axial mediastinal window sections. So what are we seeing here? There is definitely bilateral pleural effusion. Chest tube has been put in, that is seen here. And apart from that, there were some lymph nodes which were, probably seen here. And then chest tube here as well, effusion, probably some loculated effusion, and some lesions in the spleen. So multiple tiny hypodense lesions were seen in the spleen. The liver was kind of normal, nothing that we could see in the liver. And then the bones, because so we see that there are a lot of lesions in the bones. Multiple lytic lesions were seen in the bones. Some of them were expansile, and like this one, which was clearly seen on the soft tissue window as well. So we couldn't really see too many enlarged lymph nodes. So lymphoma was kind of thought to be unlikely. The blood picture was not like leukemia, and multiple bone lesions. Again, that thought for process was maybe Langerhans cell histiocytosis, though LCH normally shows findings in the lung, and it can show findings in the liver. And in this particular case, the lung itself was normal. Bilateral lung fields were normal. There were no findings in the lung as such. But the provisional diagnosis kept was Langerhans cell histiocytosis. And we advised for the clinical workup for the same. A lot of these children with LCH have skin lesions. So that becomes easy to biopsy those skin lesions, and we can get the diagnosis from there. This particular child was actually did not have any skin lesions. So about a week later, we got a call from the pediatric pulmonologist. They said that now that the fluid, her respiratory distress has settled down, we've taken out a lot of fluid, but now we saw that the fluid looked to be milky. So we got it analyzed, and it is actually chyle. So what we are dealing with is bilateral chylous effusion. And in the meantime, thinking in terms of disseminated hematological malignancy or Langerhans cell histiocytosis, they had gotten a bone marrow aspiration and biopsy done as well, which also showed absolutely normal cells and no atypical cells. So typically, even if it is disseminated LCH with marrow involvement, normally, you would get something on the bone marrow as well. So then they called to kind of request a review of the imaging. So then we reviewed the imaging, uh, keeping this in mind that what we're dealing with is chylous effusion, right? So something to do with the lymphatic system, is it? So here, now if we see carefully, this area actually, this was earlier interpreted to be representing lymph nodes, but we see carefully. So basically, this is just a very hypodense kind of lesion which is seen here in the left supraclavicular region and extending into the axilla as well. And it does not have any wall. There is no peripheral enhancement, and actually look like a lymphatic malformation, right? And even this area here actually did not really look like a loculated pleural effusion. And could this also be like a lymphatic malformation? That was our thought process. And corneal images also, if we look at this lesion here, so looks more like a lymphatic malformation. Okay, so then we kind of read up about disseminated or complex kind of lymphatic anomalies. So the International Society for the Study of Vascular Anomalies, the ISSVA, has a very systematic or the terminology. It has a proper classification for all these various vascular anomalies, be it vascular tumors or malformations. So there is, it has this subcategory of complex lymphatic anomalies. So we read up about that, and there is this entity called generalized lymphatic anomaly, which kind of fit all the boxes here. So it basically has pleural effusions, it has splenic involvement, it has bony involvement, which bony involvement involves the medullary cavity, which is what we were seeing here. So very central sort of bony lesions. And this can be, there is a lot of overlap between these conditions. So even Gorham Stout disease or vanishing bone disease also has a lot of bony lesions. That is also a complex lymphatic anomaly. Here, the difference is that there is involvement of the cortex. So that is not what we were getting. We were getting this kind of thing. So we then subsequently did an MR also for this child. And the MR nicely depicts the extent of involvement of these lesions in the bone. So multiple vertebral levels, vertebral bodies were involved, and bilateral femora, the pelvic bones, all these lesions were very nicely seen. And in addition, we could demonstrate the lymphatic malformation as well. So final diagnosis in this child was complex lymphatic anomaly, and this child has been on treatment. They did a lymphoscintigraphy for her, which was not probably very helpful, but showed abnormal lymphatic pooling in both the pleural cavities. So that was that. Okay, so next case then, this was a 2-year-old girl and had a history of recurrent admissions for pneumonia since the age of 1 year. So this case, I'll be kind of going back and forth. So we start with, when the child when we reviewed the child or when the child came to us. So previously, the child also had malnutrition, child had anemia, child also had gastroesophageal reflux, faulty feeding, and had been treated for these recurrent pneumonia episodes with antibiotics. TB workup had been done initially, TB workup was negative, but then after that, there was a bronchoscopy. So this child, I think, underwent bronchoscopy 3 times. So initial bronchoscopy showed some possible granulation tissue at the right upper lobe bronchus. So despite a negative TB workup, this was seen. Then there was a CT report which said subcarinal lymph node and necrotic kind of subcarinal lymph node. So the child had been started on ATT and later developed transaminitis. So the ATT was modified as well. So basically, working diagnosis was tuberculosis. Then in August of 23, the child had some episodes of choking. So they thought that maybe some sort of tracheoesophageal fistula has developed, maybe an acquired kind of TEF, uh, something to do with necrotic nodes or something, some kind of fistula. So basically, the evaluation, they wanted an evaluation for a suspected tracheoesophageal fistula in this child. So I got these images just for review. So I'll just just show a couple of relevant sections. So this is a non-contrast CT, and a contrast study has been done actually to try to look for a tracheoesophageal fistula. So this was thought to be a possible site of a tracheoesophageal fistula. So that's a trachea and what looks like a fistulous communication here. And we can see that there is contrast. So the contrast has been injected into the esophagus through the Ryle's tube, but we can definitely see that there is contrast within the bronchi on both sides as well. So I just got a call from my colleague, and she shared a few images on WhatsApp actually, and she said that the history is kind of consistent with the tracheoesophageal fistula, and this has been reported as that as well. So I said yes, I agree with that. This is possibly a tracheoesophageal fistula. That's what it looks like, and there is contrast in both the bronchial bilateral bronchi as well. So then the child needed a feeding jejunostomy because of malnutrition and other feeding issues, so that was done. Then in August of 23, along with just after the CT, they did a repeat bronchoscopy which was done at our institution, and they could not really find a tracheoesophageal fistula. So I think they just continued with the ATT. Though the TB workup was still negative, they still continued with the ATT. They sent the child, kind of discharged the child. Child came back in October of 23, end of October 23 now. And then again, fever, cough, fast breathing kind of thing. And then this was the radiograph. So this is a very, very drastic kind of appearance now. And here we can see that there is kind of volume loss involving the entire right hemithorax or right lung now, with these lucent areas, so part of the aerated lung which is seen here. And there is hyperinflation, compensatory hyperinflation of the other side. Other side looks absolutely normal. And so at this point of time, I got a request to kind of review the entire imaging. So I so there was a whole bunch of X-rays and a lot of CTs and everything. So I put some representative radiographs here. So the history was like about a year, almost a year old. So this was the initial radiograph. Here the child would have been about a year old, 1 year old, or just over a 1 year old. So here we are seeing it looks almost normal actually, right? Maybe slight difference in the lucency or something, probably attributed to rotation, but nothing very significant seen here. So this was December of 2022. Then in March of 23, now here we can see some opacity in this region, right upper zone, definitely some opacity here. Maybe some kind of peribronchial thickening in this region as well. Then that was March. Now this is July. So again, persistent opacity, which seems to have probably slightly more than before, but very well persistent opacity here. So some kind of persistent pneumonia in the same location that we are getting here, right? But now, end of October, this radiograph now shows more involvement. So entire lung, right lung now is now involved. So then we reviewed the old CTs as well. So this was a CT done in March, and this would correspond to this radiograph, right? And the history was from December. So this CT here, definitely what looks like a sort of necrotic subcarinal node, right? This has been reported before. So this had, like I mentioned, that this had been reported as a subcarinal lymph node and necrotic lymph node. That's what it actually looks like, right? But then if you look carefully here, though this is the mediastinal window, the airway assessment you should do on the lung window as well. But here, clearly the airway here is not looking normal. So this is the level of the trachea actually. And there's something happening here, right? And this is the level of the carina. So very abnormal looking airway here. And this is the lung window. Here also, we can actually, it looks like a very attenuated kind of airway. That's the level of the carina here. So this was CT of March. And this is the current CT, the recent one. This was November. Okay. So what do we see here? Now the entire right lung appears to be involved and showing collapse consolidation. And again, magnified image of the same. So remember that we were thinking in terms of tracheoesophageal fistula also, though they could not find that on bronchoscopy. So what are we seeing here? This is the trachea. This is the esophagus, trachea, esophagus. Then what is this? What is this? So there is this abnormal air which is seen in the paravertebral location on the right side in the mediastinum. So this should not be here. So abscess, that is what is something, so we thought of an abscess. Then looking at the airway itself. So this is the esophagus. Esophagus here on is collapsed now. We can't see the esophagus. That's the trachea. That's, the airway and the carina here. So again, this is the right-sided bronchus, and there is some abnormal soft tissue here. So after looking at all of this also, it was kind of very confusing. What are we dealing with here? So I was still kind of not too sure what is happening. So then the clinical colleagues, our pulmonologists, went ahead with another bronchoscopy. This was bronchoscopy number 3 now, which was done. So what they found was that there was a foreign body which was seen in the right main bronchus at its lateral edge, which was embedded actually. And there was a lot of granulation tissue around it. And that is what was happening. They tried to remove it. Multiple attempts were made using a Dormia basket and a tooth forceps, but they could not remove it. So this child, ultimately, they had to refer to the pediatric surgeons, and the pediatric surgeons had to open up the child. They they were able to kind of do a lavage, clean out the mediastinum if they found an abscess, and they were able to remove the foreign body, which was this kind of a plastic kind of foreign body, which had actually kind of gotten embedded there. So it had been missed on two bronchoscopies before, because it was like 3 months had probably passed between the aspiration and the first bronchoscopy. It had got embedded in the wall, and it had been missed. They saw something white. They thought it is granulation tissue. They started ATT, and what it was this kind of foreign body. And it was a big learning case for me, and it was very unfortunate that this child now landed up with almost entire right lung, kind of destroyed. So the learning here probably is that in small children, foreign body aspiration can really create havoc, and foreign body can actually move also, move in position. So probably if we think of the first radiograph, where we're not really seeing anything at this point of time, it had not caused any sort of obstruction or anything, and then thereon, it started causing obstruction and this kind of collapse and repeated pneumonia. And here also, if we see here, then probably, we can make out that definitely there is some intraluminal pathology which is happening here. So probably these multiple CTs, I think there were 3 or 4 CTs for this child, but like each would have been reported in isolation. So it's very understandable that anyone would come to this kind of conclusion. But one thing for the residents is that please always evaluate the airway, especially in children, because so many airway pathologies are there. And sometimes on mediastinal window you can miss airway pathology. So when you're looking at lung window is not only meant to evaluate the lung structures but also the airway. So do remember that, because for foreign body aspiration, many a times there won't be any history. So if the diagnosis is made in time, then we can prevent these kind of morbidity and sometimes mortality. All right. Last couple of cases, I'll just quickly go through these. So this is an old case that I dug out. I don't have the entire complete follow up of this case, but it was a big learning case for me. Uh, so this was a 6-month-old male, and this was a CT that we did. And the resident who was posted with me in CT at the time just came to kind of tell me, "Ma'am, there's a case which I want to discuss with you." So I opened it up and saw some images. So I was like 6 month old and this kind of appearance. Oh, this is some congenital overinflation. So that's what it does look like, right? This kind of, there is definitely overinflation happening here on the left side, except that it's looking a bit patchy. So which lobe, like left upper lobe, but then what exactly is happening, that, bit confusing, but some kind of overinflation. Then she told me, okay, so mediastinal window, we couldn't really see anything. So that was it. These were the corneal images here. And these were the sagittal images. So again, definitely overinflation, but which lobe, what exactly, that is a bit confusing. So there are some areas which are looking normal, some areas which are overinflated. Okay, this was the minimum intensity corneal projection as well. Then she told me, the story was May of 2015. She told me, "Ma'am, this patient had a congenital lobar overinflation diagnosed in March, and patient was operated." So these are the OT notes from 10th of March of 2015. And she said, "Ma'am, they have removed the left upper lobe because it was emphysematous." So the patient had a congenital lobar overinflation of left upper lobe, and that has been removed. So that is surgically proven. And we cross-checked, and definitely we found the OT notes and everything to prove it. So then I said, okay, then let's look at what happened before that surgery. So what was the imaging done? So this was a radiograph of 22nd February. So before the surgery, this was actually a CT topogram of 3rd of March 2015. So this is the CT that we did. It was done at our institute only. So we did in March, 3rd March 2015, and on the basis of which the child actually got operated, right? So here again, we can see the child was sick, intubated. We can see overinflation of the left upper lobe here, and some more images. So left upper lobe overinflated, yes, definitely that's the minimum intensity projection image. But what is important to see here is this. So we can see this is the left main bronchus, left upper lobe, left lower lobe, right? What is this area? Is it normal? Because normally if you get overinflated left upper lobe, there would be some passive collapse happening. So this is collapse happening in the left upper lobe.
Sorry, I think there is some issue with Dr. Pooja's net connection. She'll just be back just a minute.
Sure, sure, ma'am.
We've been seeing some excellent cases with lot of learning. Hope Dr. Pooja can log in quickly. Yes, Dr. Pooja is back.
I'm
Sorry,
so
we
sorry.
lost you for a short time. Yeah.
Yes, ma'am. My device decided to restart on me, so I'm
Oh,
sorry.
okay.
So I'll just quickly. I think I've already. I hope that my slides were visible till the thing happened.
Yes, yes, yes.
Okay,
Just for just 1 minute only. We lost everything for 1 minute. That's all. Last 1 minute only.
I'll just.
So really great cases as you are setting it up again. Can I ask one question as you are setting it up
Yes, ma'am. Please do.
about the contrast when we are suspecting tracheoesophageal fistula? What is your protocol? What contrast do you use?
Ma'am, actually, frankly speaking, we've not really done these cases at our place, though
Okay,
we would. But I think that if I had to do this kind of investigation, then probably we would
because
use.
the yeah, because the worry will be about like if gastrographin kind of goes into the lungs, it can draw in a lot of fluid and cause edema.
Yes, ma'am.
At the same time, if we use barium, if it goes into the lungs, it will be inert. But if at all there is some communication to the mediastinum, it can cause a lot of mediastinitis. So we
Yes,
kind
ma'am.
of
I think
thought
barium though would
maybe,
not be. Yes,
uh,
ma'am. Ma'am, maybe it would be in small quantities if we are using non-ionic contrast. Then
yeah,
usually they say that I think we should use as less contrast as possible to uh, and if we are getting any sort of aspiration or evidence of fistula, then we should probably
stop
stop
immediately.
it there.
Yeah. The other thing that we can do is the isoosmolar like iodix and all. So even if that gets aspirated, since it's isoosmolar, it won't draw a lot of fluid. So that may be another thing that we can use.
Yes, ma'am.
Yes, your slides are back. Thank you.
Yes, ma'am. So basically, I just got this case. So finally, what happened to this child now? Actually, I don't know because I think initially the child did not really give consent to a repeat surgery. But the point was that on the initial CT, probably these are the initial CT images now. This is the CT that we did before the child was operated. And So here, that is what happens, that we looked at this probably, and by we I mean whoever, like whoever one of us was reporting it. So we kind of fit it into the congenital lobe or overinflation, yes, of the upper lobe. And then we kind of missed out on these findings that even the lower lobe is not normal. And then, so this is a comparative. This was March of 2015 and this was May of 2015. And so this is the part of the upper lobe which was overinflated, which was removed surgically. And then kind of the lower lobe was also not normal. So then it kind of overinflated, and the child again, in such a short span of a few months, again became symptomatic. And if the we need to be a little more careful, especially in congenital lung anomalies, and in everything really. That look at everything. Once you think you made the diagnosis, yes, that's what probably happened. We were very happy that okay, it's a congenital overinflation of the upper lobe, and that's it. And we kind of missed out on something which actually had great implications for the management of this child, actually, because after surgery, the symptoms kind of happened again. So just one last case, recent case. This was a 3-year-old girl, and had wheezing, and was showing in the asthma clinic. And this was a CT that we did. This is 1st of August 2023. And these are the images. This was reported as normal. So that is quite understandable, actually, can be reported as normal. But then again, kind of just try to stress on the history. So this child is having recurrent wheezing, and a 3-year-old child. So look at the airway a little more carefully, probably. And then maybe some subtle findings, like there is some differential attenuation. And probably corneal images might show that difference better. Here on the axial also, we can compare. This area is looking more lucent or darker as compared to this area, which is less lucent. So this child then underwent a second CT, which is the time when we kind of went back, reviewed. So now this is November of 23, and now probably the area of mosaic perfusion, air trapping is now more obvious, which is seen here. So this child basically, since the child was having so much of wheezing and all that, they had put the child on steroids, and then the child started having some fever, something, whatever. So then they got this CT repeated because of that. And on this CT now, the airway changes are also more marked, so kind of more easily picked up. And then this is a contrast CT. So now what we saw was so previous CT, the mediastinal window was normal. So even when we went back, reviewed it, there was nothing. So the only finding on the first CT was this kind of mosaic perfusion, air trapping, some areas, some patchy areas. Now the child had definite enlarged lymph nodes as well. There were some nodules also which were seen here. And the child TB workup also was positive. So this was a post-infectious bronchiolitis obliterans. And since these children are treated with steroids, then in our country, they can always be a reactivation or a reinfection with tuberculosis. So it's important for us to remember that as well. And post-infectious bronchiolitis obliterans in children usually happens after respiratory tract infections. And CT has an important role to play to kind of demonstrate areas of air trapping, mosaic perfusion. Sometimes bronchiectasis may be seen, but not always. So, and it's important to diagnose this entity early. Why? Because there is inflammation, post-infectious inflammation, which is happening. It is causing obliteration or narrowing of the airway. So, if these children are treated with steroids, and if treated early, if the steroids are given early, then kind of they can sort of limit the damage to the airway. So with that, I'll just hand it over to you, Aparna ma'am, to talk about the upcoming SciCon.
Thank you so much, Dr. Pooja. That was so nice, so many nice, interesting cases, and so much of your experience you shared. So
Thank you.
again, I would like to invite everyone for the next annual conference of SCII, that is SCICon 2024 in Bengaluru, and Dr. Vimal Raj will be organizing it. So please mark your dates. The registration forms will be out soon, and residents, please keep your posters and papers ready. I just want to just reiterate some of the points that Dr. Pooja said. Uh, so about this TB causing bronchial narrowing, that was a very nice point. that I learned today. I'm just saying what are the things that I learned today. So lower lobe is almost never involved in congenital lobar overinflation, that I think Dr. Pooja has stressed again and again. So that is one good point to remember. So if that is involved, think of other causes. One thing from my side I want to add. So whenever in children, we see that uh, we tend not to do the contrast studies, and then we miss a lot of things, like we miss nodes, we miss, there may be other anomalous vessels, all those things. So best is to do a contrast study right away. Not, um, I mean, the delaying of the contrast study is going to delay a lot of the diagnosis, and we don't have to do multiple phases. We don't need plain, arterial, venous, etc. We just need one good contrast study with good contrast in all the vessels, which we can easily achieve now with all the machines that we have. Dr. Pooja also stressed about coronal and MIP images, MINIP images, all those reconstructions and the coronal, how those are also helping us to look at it from different angles. And bronchiolitis obliterans, the last case, that we do see a lot of those. So one way of bringing out that, like in adults, if we want to look for air trapping, we do expiratory scans. But
Yes.
in children, we're not able to ask them to do the expiratory. So one thing that we can do is we can just do a few sections with right side down and right decubitus and left decubitus. So whichever side is down, that is like as if it's expiratory for that side.
Mhm.
But obviously, we're not going to do the full from apex to diaphragm, the whole study. So we can just do few images, like 1 mm section at say 20 or 30 millimeter gap. So there's not much of radiation, but it will very, very much help us in the diagnosis just by putting one's right side down, left side down. It's like expiratory for right side and expiratory for left side. And then that air trapping will be brought out very easily. So thank you, Dr. Pooja. I invite Dr. Ravinder to propose a vote of thanks. Ma'am.
Thank you, Dr. Parna. Dr. Pooja, it was really very interesting session. All
Thank
the
you.
cases were very beautifully worked up and explained. Some of the cases are very rare. Like one of the cases you showed about the cystic changes in the tuberculosis. I
Yes,
have
ma'am.
maybe we would have seen, but maybe we have missed. But I'm not very sure how common we see this cystic changes in tuberculosis. So I think we will have to rule out all the things. Only then it is possible with the clinical history to reach the final diagnosis.
Yes, ma'am. Definitely, this is like we need the clinical history for this. And this was the first case. I never saw a case before this, ma'am, the one that I showed. But then after that, we have seen maybe three, four, I think five cases we've seen. And we
Mm.
actually published our experience with Rama, ma'am. We recently published our experience on this kind of cystic case series on cystic tuberculosis as well. So now that probably that, once we saw one case, then from 2019 till now, we saw like five cases. So probably,
Okay. So we are wiser now.
yes, ma'am.
So I would like to thank Dr. Pooja for wonderful session and also want to congratulate to you. And Dr. Parna, thank you so much for chairing this session. And I would like to thank our digital media partner, Clarinet team, Ankita and Sangeeta. Thank you so much for organizing this webinar seamlessly. Thank you all. Thank you all the participants and all the residents or other participants who have joined for this webinar. Thank you all.
Thank you
Thank you,
so
ma'am.
much, everyone. Thank you so much, ma'am. So, with all due permission, I'm closing the session here for today and looking forward to hosting you again. Thank you once again.
Thank you. Have a good
Thank you.
weekend. Bye.
Thank you. Thank you, ma'am.